All right. Hello, everyone. We are here with Mettle Health Counselor Claritza and AJ, a member of the Mettle Health community, and we're going to be literally going through some advanced care planning documents together in the hopes that this conversation will be helpful to others who might be filling out their own documents. Claritza and AJ, can you introduce yourselves?
AJ, you want to go first?
Oh, sure, thanks. Hi, I'm AJ. I live in Washington, D.C. I am living with chronic illness and I use they, them pronouns. Um, yeah, I've worked through some advanced care planning documents in the past, but I'm looking to update them with my recent move and just kind of finalize some outstanding questions that I had.
Awesome. Thank you so much, AJ. I am Claritza Rios, and I am a physician counselor here at Mettle Health. I have specialty in palliative care, emergency medicine, and internal medicine, and I am really excited to have this conversation today. Um, yeah, so shall we get started?
Yeah, let me share. AJ has picked 5 wishes, so that's what we're going to be sharing here.
So there are several advanced care planning forms that are available. Different hospital systems have different forms. 5 Wishes is one that is available all over the states and is really straightforward. And a lot of people choose it because it's super um, non-medical person friendly in terms of um, making decisions about their health care. And so we'll go through them. I think it's important to note, and AJ, I don't know if this ever came up for you, but as we're talking about advanced care planning, the key thing about it is to see it as um, making sure that you're documenting your wishes in case that you're unable to speak for yourself. So you're always going to be in control of your decisions at all times. But if there's a situation where you don't have the ability to speak because you're, under some medical treatment, or you don't have the mental capacity to engaging in decision making for yourself, that is when these things get enacted. That is something that sometimes comes up. I don't know if it has ever come up for you, AJ.
So definitely, I mean, just that understanding, because sometimes you kind of get into the nitty-gritty of like what you want now, but it's really important, I think, to remember that it's really for that period where you may be unable to make those calls for yourself. Yeah.
So with 5 Wishes, and generally with advanced care planning documentation, there's big themes that come up. And one that's very, very that drives a lot of the documentation is um, assigning a healthcare agent, a healthcare proxy. These are terms that we use a lot. What does that mean? It means that you are deciding, assigning a person that you want to make healthcare decisions for you when you are unable to make them for yourself. And so when we think about this, immediately we go like, well, isn't that understood that it's going to be my partner, it's going to be my big sibling, or it's going to be my mom? Um, it could be anybody. The key thing to understand is that when you're picking a healthcare agent, it has to be somebody who will literally be your voice if you are unable to speak. So want to make sure that we're taking that into consideration, because when we have a village, the village loves us hard, and sometimes love and responsibility and trauma can make you make decisions that may not be the decisions that the person that made you an agent would. And so it's really important for people to consider that there's no default healthcare agent that we expect. You pick whoever you want. And so in this case, AJ, do you have any questions about wish number one and who the person would be?
Well, I've had a lot of discussions with my excuse me, with my mother.
Okay.
Throughout my illness, I've been dealing with cancer diagnosis for going on 10 years now in total. And my mother's been my main caregiver through most of that time. And so that's the person that I've felt most comfortable with as my healthcare agent or my proxy. Although currently we live in different states. So I thought I would also want to like add a second person who I've also had discussions with. And that's my sister who lives locally here.
Mm. Awesome. So we would write that in there. Depending on the state form for the folks that are watching this, you do have an alternate or a second person as a proxy. That's always really helpful. Sometimes there's situations where we need to make decisions right away in a healthcare system. And if we can't get one person on the phone, it's really helpful to get the second person on the phone. Situations, as you mentioned, of just proximity can really be helpful in sort of deciding who that second person is. And what I love most about what you said, AJ, is that you've had conversations about these things with your loved ones. It's so important that when you pick the person, you say, this is you're the person. Are you down with being the person? But
Mm.
also this is the way I want to be treated. How do you feel about being my voice? And really sort of unpacking any barriers to that. And if there's a bunch of barriers, for somebody being able to engage and being that voice, just really taking a step back and saying, okay, maybe this may not be the right person. You can be a support in a different way.
I have a question about the healthcare agent or proxy. What if, I pick two people and something comes up, a question comes up and they don't agree?
So that can come up often. I think that these are situations where you want to kind of pick people that will work together and come to a consensus. If you want them to um, if you say, Mom, I really wanted you to check in with my sister about this, or whoever the person is. But usually the healthcare agent will be the decision maker. The first person will be the decision maker. But I often recommend, and we will say that lawyers, and depending on the state you're in and the institution you're in, consensus is really important. If there's somebody that protests and they have um, a good reason for having a protest. But by and large, we recommend folks that will be able to come together and if they disagree, reach a consensus in your best interest. And so I think those are really great questions to have, AJ, with mom and sis of like, it's important to me that if there's a disagreement that you can come to a middle ground. Where are some of the prickly parts where you think this could come up? It's a tough conversation, and sometimes it's helpful to have it with somebody in the room, like a palliative care social worker, doctor, or team member.
Sure.
Was that helpful?
Yeah, thank you.
All right. At any point, if I answer something and it's just not enough, you keep asking. Okay.
Okay.
Awesome. So we would post healthcare agent and then the alternate. Most state forms will have the primary person and the second person. And usually, if you want to scroll down a little bit, there's some requirements to who the person is. For most states, it has to be an adult, somebody over the age of 18. But in Colorado, it should be somebody over the age of 21. Other things that they want to make sure is that they're not your healthcare provider, like your primary doctor. There's some concerns about, the agent being able to make decisions themselves, right? So that they're of sound mind. So sometimes we'll have a patient whose partner has dementia, and they start to lose the ability to make decisions for themselves, and that becomes a concern. And so you want to be mindful, if you did a healthcare proxy 10 years ago, to check in and say, are these the right primary and alternate person?
Sure. And I saw that, so I got the 5 Wishes online,
Mhm.
an account online, and I can go back there, I saw anytime. Like I can log in and change things as
Yeah.
often as I want. So I think that's kind of a cool thing. And
Yeah,
then
and
I
I
can print it out as well.
you bring up a really good point, which is that at any point, if you say this is no longer honoring my mindset, so rip it up, change it up, or go into whatever form you're using, if it's electronic, and adjust it as needed. That's a really good point. None of this is like unchangeable. As long as you're of sound mind, you can absolutely change your healthcare proxy. Awesome. And different forms will have different ways of doing it. Some want you to cross things out. There are some states actually, and really important, like North Carolina wants you to have things notarized. And so the minute there's like a diagnosis, or the minute you know what you would want, um, at least at high level for your healthcare, if you weren't able to make medical decisions, start looking at these forms, because you don't want to be getting treatment and having to drive back and forth from somewhere and have to go find a notary, or and so the sooner we do these things, the easier it is for us. The cool thing about the 5 Wishes is that it tells you what paperwork, what's the witness situation, how does this have to um, be filled out to be valid. This form is really fantastic because it also tells you how the healthcare proxy, what they're empowered to do from a healthcare decision standpoint. And so as you're assigning your sister now, and she sees this list of things like interpreting instructions that are given by healthcare providers, talk consent to donating organs, applying for Medicare, all these things, um, are they up for it? And if not, then how do we get there? How do we inform ourselves about these things? Is it a conversation with you? Is it a little bit of research? Do we cross that bridge when we get there? These are the things that will help somebody get mentally prepared.
Yeah, and as I was kind of looking through the rest of the form, I noticed some things where, it's a good start on the form, but then there's more details that I would want to go into as well. Um, so in some places there's a blank where you can fill in more details and then kind of follow up by having those conversations is my plan.
Yeah, yeah. And the form is biased in its way, right? It's written as conscientiously as possible, but it probably doesn't take into consideration culture, um, religion, sort of, so every aspect of socioeconomic situations. And so these like open spots on the document allow you to personalize it so that it's more bespoke to you and your wishes. That's a really good point. Thank you, AJ.
Mhm.
Awesome. We can see that. All right. And so wish 2 is my wish for the kind of medical treatment I want or don't want. This is very nicely laid out in 5 Wishes. In state forms, it'll be more about, do I want aggressive healthcare treatment? Or it'll say something about critical care type treatment, or it'll speak more about life support. And so this particular form, I'll just read it just so that, because this is where we're getting to the juicy stuff. And then AJ would love to have you take it from here and ask questions or let us know where you're at. So I believe that my life is precious and I deserve to be treated with dignity. When the time comes that I am very sick and I am not unable to speak for myself, I want the following wishes and any other directions that I have given my healthcare agent to be respected and followed. And so, um, keep what you should keep in mind as my caregiver? I don't want to be in pain. I want to be comfortable. And then wish three talks about that a little bit more. I want to be offered food and fluid and by mouth, if it's safe to do so. I want to be kept clean and warm. I do not want anything done or omitted by any doctor or nurse with the intention of taking my life. And so this kind of gives some uh, ideas of sort of how people want to be treated. The reality is that in the United States, the healthcare system, the majority of the time, unless somebody tells us if you are critically ill, if your heart stops, if you are in some way an organ is failing, if you're unable to speak for us, we will engage in critical care, life supporting treatment, um, independent of whether we think it will necessarily make your life better, improve your life, or make sense based on your values, because we don't have that information always in front of us. And so we will go really aggressive life supporting treatments. And so people need to tell us, I want I actually want some treatment, or I don't want aggressive treatment if I'm going to be uncomfortable or in pain. Um, and so that's an important thing for folks to know, not the mindset, but sort of the idea of the American healthcare system is that we give you all of the treatment, whether or not it aligns with your values or it makes sense based on your diagnosis or how you want to be treated. And so that's important to know, because it sometimes feels like by making a decision or signing a piece of paper, you're getting things taken away.
Mm.
But in reality is we're trying to make sure that we don't do anything that isn't going to be helpful based on your values and what's going on with you medically. Anything you want to say to that, AJ?
I mean, I think these bullet points, these 4 bullet points under what you should keep in mind as my caregiver. So those are directed to my mother, for example.
Mhm.
And they seem pretty universal, but like the last one is just kind of oddly worded to me. I'm just curious if you can kind of speak a little more about what that means.
Yeah, I think every time I read it, I'm like, I don't always feel like that is communicating what it's meant to communicate. So I do not want anything done or omitted by my doctors or nurses with the intention of taking my life. The reality is that we wouldn't do anything to take your life, because it is a crime to to do
Yeah.
anything that would take your life. And so um unless there's very specific treatment, and this is beyond this meeting, but there are states that allow for medical assistance in dying, um, that it would be the only time, and they're very specific protocols, very specific diagnosis, lots of conversations that would need to happen. And so, yes, AJ, I think that the writing of that, and it's funny because I've had this conversation several times with patients. I think it's there because it wants to honor the idea that we all take the Hippocratic oath or a similar oath of doing no harm, and that um, because there's this feelings about death, dying, decline, and people sort of not being heard with chronic illness sometimes, that we want to make very sure that everybody filling out this paperwork knows that we would never do anything to expedite death, to not honor your wishes, to do anything to cause harm. But yeah, it's a little it's just uncomfortable, I think, to see
Yeah.
it written in that way.
Yeah. Thank you. That makes sense.
Yeah, totally. Just so that we are sticking to the document, life support. What does that mean, right? It's important for us to be able to know what it means in general and then what it means to you. So life support means any medical procedure, device, or medication that would keep you alive. So life support treatments include medical devices that put in me to help me breathe. Many of folks will hear that as an endotracheal tube or a tracheostomy, food and water supplied by a medical device, tube feeding, G-tube feeding, nasogastric tube feeding, CPR, which is a procedure in which we try and get the bodies to circulate blood and also restart, shall we say, the heart if it has stopped beating. Major surgery, blood transfusions, dialysis, which is sort of artificial filtration of the blood to replace the kidneys, antibiotics, and anything else meant to keep me alive. If I wish to limit the meaning of life support because my religion or personal beliefs, I will write down the limitations on the space below. I do not think I do this to make very clear what I want and under what conditions. And so anything where we're doing things to help you stay alive, even giving you water, can be life support. But most people think of it as like the machines and the tubes and the CPR. And so I think it's helpful to be able to define it for yourself.
Right, yeah, that makes sense. So this is really a section that's just kind of setting out a definition. It's not where I'm going into what I want. Is that how I'm
I
reading
mean, you
that correct?
could say, for example, somebody could say here, um, life support for me means, intubation, ventilatory support, and artificial nutrition.
Okay.
Um, or they could say, no, this aligns beautiful. Anything that's gonna not, if I can't do it myself, then that's life support to me. It's a fair thing to consider. And that's where the most will come in, even further. So we can definitely get more granular there. But this is um, also helpful to kind of go through it uh, because I think if we ever need to help your healthcare proxy define what that means for you is really reasonable. But happy to answer any questions about specifics on those.
Um, well, I guess, can you talk a little bit about how some of these things might look? Like I'm not super like I've never experienced that where like someone that I knew needed to have life support treatment.
Yeah.
Um yeah, I don't know, would you be open to like going through at
Yeah.
least some of those?
Yeah, of course. So when I think about um I think about it as sort of levels, right? We know about CPR and intubation. If your heart's not beating, then and your heart stops, you can have CPR done, which is an attempt, not an attempt that is not often successful, but definitely possible to resuscitate, to restart the heart after somebody has died and their heart has stopped. That is life support to the at its most uh, highest level. Um, when somebody's getting CPR, they're also not breathing. And so we would initially, uh, CPR itself is pumping on the chest with what we call chest compressions to get some external force to help pump blood around. Um, it is very much done on TV, and everybody always wakes up and high fives the doctor. That's usually not what happens. Usually CPR was initially put forth for people that had a heart attack, and in that first 24, 48 hours was at risk of having uh, their heart stop because of funny electricity going through their heart after a heart attack and having scarring, and we then kind of ran with it and use it for everyone whose heart stops, whether they're 1 year old or 100 years old. And the success with that varies. And so CPR is at the highest level. Intubation also is, and ventilatory support is another form of life support. Intubation means that you have an endotracheal tube, which is a tube about yay big, a little bit smaller if you're a smaller person, a little bit bigger if you're a bigger person, about the diameter of like between a dime and a nickel, maybe a nickel, that is introduced down your trachea, so into the mouth, down to the trachea, your breathing pipe, that then would get connected to a bag initially, but then eventually to a ventilator to help support your breathing. You don't only get an intubation when you have when your heart stops, but sometimes people have a bad infection, something that they need support through for a few days while we're giving antibiotics, and that person then can be intubated. Intubation usually means if you are alive and we choose to intubate you, it's very uncomfortable, so the person will have to be sedated. We give you sedative medications, sometimes depending on what is causing the respiratory failure. We would say if you're not breathing, you would be in respiratory failure. We would also maybe give you some paralytic medications, some medications to stop the movement of the chest, and we would be doing all the movement, but we would have you sedated so that you wouldn't feel the discomfort. Those are really big and kind of what people think about uh, life support. And it's important to note that when you think about life support, it's not so important to think about, or of course, everything's important. I don't want to minimize it, but you don't worry so much about like, well, what about all the scenarios? What if it's pneumonia? What if it's this? What if it's that? I think it's important to think about life support. What is it gonna get me to? Is it a bridge to something that will honor who I am and honor where I want to be? Or is it just something to keep me alive, which may be honoring, right? If being alive is the goal, then that very much would honor your wish. But it's important to think about it. The healthcare proxy and you yourself right now, as you're thinking about all possibilities, it's difficult to think of every scenario. So maybe think more about like, if something's a bridge to X, then I'm willing to do it. If something's a bridge to Y, then okay. What are the things that I'm willing to do? Am I willing to do time limited trials, or are things just a non-starter? Are the things to think about, because I think as I give examples to be able to explain the procedure, sometimes then that gets you, wait, I'm going to go down this rabbit hole, all possible things that
Yeah.
could be happening. And besides it being scary, it also is just a thought exercise that has unending possible treatment or possible situations for the treatment.
Yeah, I hear you, Claritza.
Um, and I'm sorry, I'm doing so much talking here.
That's okay. I appreciate it.
This is usually a lot more of a conversation, but I realize that a lot of this does need some explanation. So at any point, just time out or let me know uh, if you have more questions.
Well, I mean, I guess on that first level that you were just talking about with CPR and like ventilation support, to me that sounds like too much. Like it sounds like, I mean, my main goal is really like comfort. And so I just, in my understanding of CPR, like it's a pretty traumatic event to have CPR. And, you know, like you said, it's not always successful. And I think that if, I'm in that situation where, you know, my heart is stopping, I'm unable to breathe, things like that, my like gut says that that's not really something that would be like in line with my goals.
Mhm. So I think you just really hit the nail on the head there. It is pretty hardcore stuff, right? And so, and it's available, right? It's available. We
Right.
offer it to people, and it's a default. And so people think, well, if Claritza says it's available, then it must mean that she thinks it's going to get me back to health. And the reality is that um, it doesn't always, right? If it's again, I'll give you examples. I've had patients who, you know, had a pneumonia, and the pneumonia was just really severe, and they were otherwise 24-year-old healthy kid in college, and we just had to support them through the pneumonia, and intubation worked beautifully there, and we treated them, supported them. There were some little complications here and there, but they were healthy enough to bounce back. Intubation in somebody with a chronic illness, or somebody with advanced age, or somebody with debility, frailty, dementia, the outcome may not always get you back to where you were or better. And that's what we always want, right? We want you to get you to do treatments that get you back to a stable place or better. And so I think you're really and of course, because I know that your goals are comfort and to live as long as possible, as comfortably as possible. Um, I think that this kinds of treatments would not honor that necessarily, considering your diagnosis. And I think that that's a fair question to ask your provider. Given
Mm.
given my current state, or given the evolution of my illness, if I get so sick that my heart stops, what does if I survive this life support treatment, what does the future look like? That's a really fair question to ask. Um, Things like antibiotics, things like IV hydration, things like certain medications to kind of help your blood pressure can help for some period of time. And that's where the most comes in, where you can really kind of get really specific about it, talk about time limited trials. You know, is it always the case that treating an infection is always going to be helpful? And we always default to treating infection, but it may not always meet the goal of comfort all the time.
Mm.
It can, but it doesn't always. And so that's where the most can be really helpful. I realize that we're really staying a lot on this one, but I think it speaks to the importance of going through this and working it out in your head, because um, there's a ton of possible outcomes, and you want to make sure that you're armed with information.
Sure.
The great thing again about the 5 wishes is that you can really get down to, if I'm close to death, these are the things that I want. If I'm in a coma and not expected to recover, these are the things that I want. And the options are, I want to be on life support, I don't want to be on life support, or I want life support if we think that it's going to be a bridge to something, or if the doctor believes that it is going to help. And
So
help.
that's what it means by help there, right? Is that what you're about to say?
Yeah. So
Okay.
define help. What do you mean by help? Help
Yeah.
for you could be my heart beating. Help for me personally is that I'm going to wake up the same or better. For AJ will be different. Comfort and live as long as possible, as comfortably as possible. So even in these documents are so specific and so um, easy to read, there's still some nuance that we're missing. And so that's why it's really important that you talk to your provider. And so, yes, in my mind, I think there is, based on what you said, that maybe that third option makes a lot of sense, with the understanding that we want to define what help is. And that's where your healthcare proxy can really um, weigh in on that.
Gotcha.
permanent and severe brain damage, and not expected to recover, and then any other condition. One of the things that's really hard is with different conditions, different people, age, um, life experience, actual diagnosis, stage of a diagnosis, their prognosis can be different. And prognosis means what we foresee. Is their course of disease, when we think they might die. That's sort of in general what we mean by that. And so it's really important to ask the question, if that would be helpful to you, of based on my prognosis, would this be helpful? And this is what I mean by helpful.
Okay, that
Make
makes
sense?
sense. Yeah.
All right. And so with wish 3 really talks about comfort. This um how much I am willing to put my body through in order to prolong my life. I think that's a fair way of saying it. And it really goes through all the, not all, but a lot of wishes um, that can speak to, and hopefully they're conversation starters as you go through them with your healthcare proxy. This will help you. Um, the idea is that you would cross out anything that doesn't make sense make sense to you. And so we can read through some of them. I don't want to be in pain. I want my doctor to give me enough medicine to relieve my pain, even if that means that I'm drowsy. Um, if I show signs of depression, nausea, shortness of breath, I want that to be treated. If we go to the other column, if I am not able to control any bowel or bladder functions, I wish for my clothes and bed linens to be kept clean and for them to be changed as soon as they can, if they're soiled. And of course, this is usually the default, right? We want to make sure that you are well cared for. But again, I think the form also is to speak to, this is kind of therapeutic now, to know that everybody, by making sure that that is there, that you are um, feeling like, yes, I am going to be cared for. And there are some people
Yeah.
that feel like I don't care about that, but I think it's helpful to have these things in here. Anything in
Yeah.
particular that sticks out to you?
Sure. I mean, I think what you were just saying resonates in terms of, I mean, this kind of gives me this sense of a little bit of control over, a time where there wouldn't, be any control, in the moment. So yeah, I mean, I really want people to know what's important to me. But I am curious,
Yes.
in your experience about pain. Um, if I'm unable to speak for myself, like how do folks know what my level of pain might be and like how to identify that?
Super good question. So helpful. So certainly if your mom's advocating for you, we love in hospice, palliative care, inpatient setting, we really try to follow the lead of the person who knows you most. So if your family member, if your village is saying they don't look comfortable, then we will treat. Um, but usually it aligns. There is a lot of things that happen to your body when you're in pain. Um, the way that you furrow your brow, the way that you hold tension in your muscles. And so we have all these tools that our colleagues in nursing use to assess for pain. Um, and in general, if we know that something costs you pain and now you're unable to speak, it doesn't mean that you're not in pain. You're just not expressing it. Hey, I'm 9 out of 10. And so we would continue pain medication. Um, and that um, it's really important that if that is like, I'm going to sound silly, a pain point for you or an area of concern, to make
Yeah.
sure that that is highlighted in when you're speaking to your caregivers. Like if I even so much as look like I am in pain, to make sure that my pain regimen is really solid. Um,
Yeah.
and certainly worth mentioning to your primary team as well.
Right. Yeah, that makes sense. I mean, I know that I have a like pretty high pain tolerance and I'm very sensitive to pain medications, like they're very effective on me. So yeah, that's just something that I would definitely go into with my team, proxy and doctors and everything like that, just so they're aware of that. Because I think I wouldn't want to be um kind of drowsier or sleepier than I need to be.
Mm-hmm.
Um, it
Mm-hmm.
just because I think it's such an important time of life that, um, I'm kind of interested in the experience, so
Yeah.
that's helpful to know.
Yeah, and I think that is so important, AJ, to discuss because a lot of people, there's so much fear about discomfort, but there's
Mm-hmm.
also fear about not being aware, not being able to feel somebody's hand on yours. And all that stuff is negotiable when you're able to speak to your needs. Certainly, a lot of times patients will say, wow, I really love the pain medication, but it just knocks me out and I'm having visitors. And so I want to interact with them. And so we say, hey, let's adjust your pain regimen today um, to the point where you're tolerating it, but you're not so dissociated that you're unable to interact. And so everything is titratable. Everything is um, able to be adjusted to honor the moment. And so when you lose that awareness, having this um, discussion helps the providers say, okay, um, we want to be able to give them the experience while at the same time treat their pain. And there's a lot of unknowns, right? And so we can only do the best that we can because obviously it's not 100%, but the more information that you can give people, the better. And I think you're doing that.